Perfect. So thank you for all these discussions. And now we are going to have Soosan Jacob. And Soosan, please go ahead.
Thank you. Thank you so much, Pavel, Arthur, and AECOS for inviting me here. These are my financial disclosures. I do consult for Madhu and Zyma, and I do have a patent which has been issued for the special trifine that I'll be showing you here. My talk is on corneal allogenic intrastromal ring segments, and this is basically very similar to the Intacs or the synthetic ICRS, except that I started doing it from allogenic tissue. And the source of allogenic tissue, of course, could be anything, any kind of tissue, fresh, preserved, processed, or in any form. But the common one that we use in our hospital, because it's so easy to obtain, is just a donor cornea, from which we remove the epithelium and the endothelium. And then we cut it with a special double-bladed trifine and insert it into the cornea. So this is a video which I have actually shown many times, and I think many people would be familiar with it. And if you can see that the segments are uniform from end to end, and you could put one of them or you could put two of them, depending on the type or the topography of the patient. But what I'd really like to share with you here is this case, which is basically where we have started doing now, customization of the care segment. So this is something that we've also been doing for a few years now. But I've kind of now developed the instruments and the designs, the devices needed to be able to do this to a much more accurate extent now. And you can see this is how the cares is cut, and that's how we customize it. And basically the customization is done so that you can get a gradient effect or a gradation of the effect, so that you do not want a uniform flattening everywhere just because the patient has got keratoconus. Sometimes you need differential flattening, and the customized cares allows you to do that. So this is the technique. This is a double-bladed trifine, which cuts this annulus of stroma. The Bowman's membrane side is marked so that we know which is the side that goes towards the pupil. These are all instruments that I designed, and this is the CARES customizer. And what we do is here, I cut that CARES customizer into the shape that I want, and then we plan on the patient's topography as to how we want it and cut accordingly. So I'll just show this in a little bit more detail in a patient's eye. The advantage, of course, is you can have any kind of customization, different shapes depending on the type of keratoconus that you're encountering. It could be progressive thickness, progressive width, the combinations. You can have different transitions or options, because all of this can be done by us. And we as ophthalmic surgeons, we know we've been operating on the cornea for many years, and so who better than us to make these kind of segments. So progressive cases, of course, it goes without saying, needs to be combined with cross-linking. CARES alone is not the solution. So here's again a video that shows customization a little bit more in detail. That's the double-bladed trifine, and you can see that I'm marking the Bowman's membrane side, and this is basically being placed on a customizer, and the transition marks are marked. So this is how I had started out first, and that was an ETO sterilized laminated marker, which I had taken as a computer printout, but then we got it designed with a titanium instrument, and all the optic zones and all the clock hours are marked on that. And if I can just go back to that again, we have all the optic zones marked and all the clock hours of the degrees marked. So what we do is we lay it on the optic zone that we want, and then we mark the kind of topographic cuts that we would like, and then we lay it out on a Teflon block and cut accordingly. So this can easily be done, of course, with just a sharp blade, and it's really very easy to do once you've got your plan marked out. So you can see here from 4:45, that's where we put the first mark, till 7:15. We wanted a uniform segment, uniform thickness segment. So we marked those two out. And then we wanted a taper over here, which would taper from till about 9:15. And so till 9:15, we marked that. And you can see that what we cut will exactly correspond to the topographic pattern. So that's what we've done. And this is the patient's eye. Again, instruments that I've designed, the degree zone marker, as well as the single radial marker, which allows you to put those marks exactly on the patient's eye. You can also, of course, put the patient on the slit lamp and mark the horizontal axis before starting all of this. And once we do that, we just insert the CARES segment into the femtosecond laser dissected channel, and you can see that it exactly corresponds as per plan. So that's basically the beauty of the whole procedure, that you can customize it exactly according to the plan and translate it exactly onto the patient's cornea. So having said that, we know that CARES does get rid of many of the disadvantages of synthetic implants. We are able to implant it in a much smaller optic zone. We know that synthetic segments are generally not put if the Kmax is more than 58 diopters, or if there's not sufficient corneal thickness in the zone of implantation, or even in pupils which are larger than 6 mm. But in all these situations, you can still go ahead and put CARES. It can easily be put in all of these because it's allogenic, so it's safe. And that's what we do. Here's a patient with corneal melt where I've removed that intact and replaced it with a synthetic segment. You can see that you can put thicker segments and more superficial placement and smaller optic zone, all of which gets you a greater effect with CARES as compared to synthetic ICRS, which by default you have to put at a larger optic zone and put it deeper. And of course, there's also a limit to how thick you can go with a synthetic segment. With CARES, the other advantage is that you do not have all these photic phenomena even when you go to smaller optic zones. So that again gives you greater effect. Here's a patient for whom we had removed the intacts and put in CARES. And that's a great way to actually cure these stromal defects that are caused by post-intact melts. I will just go to just some topographies. Here you can see how we put in a single segment, and it gives you this flattening along with a corresponding steepening in the opposite axis. And these are, of course, all different kinds of customizations that you can do. You can even do centrally tapered, as you can see here, exquisite customization, actually. You can do two rectangles connected by a small band, and all of these, as you can see, can be exactly translated into the patient's eye, depending on where you want more flattening and where you want less flattening. We've also started doing femtocares, and I'm collaborating with Zymer for this. Here you can see Badak Hayat from Germany has created a circular CARES, which is very much like a Mayo ring, which he puts into a pocket that's created in the patient's eye. And that's the patient post-operatively. These pictures are courtesy Badar. And here's my experience with femtocares using the Zymer Z8. I did this with Dr. Kumar doctor in Mumbai. And you can see here the beautifully cut asymmetric segments, the customized CARES, which you can also create with the Zymer. And they come out really beautifully. And here's a patient with a segment implanted post-operatively, and you can see it here as well. So this was our experience at Dr. Kumar's clinic. This is the software that's being used to create these customized segments. And of course, you can also create the femtosecond tunnel, making it an all femto procedure. I'd also like to share with you a technique which Shady Awad has done, where he dehydrates the CARES segment to a large extent, which helps you to kind of almost push it in very similar to a plastic piece. You can see that once it's dehydrated, it just goes in, and you can just push it in with great ease, so that, it's very similar to implanting an intact then. Of course, even if it's not dehydrated with the right instruments, you can still push it in with ease. But if you want a little bit extra degree of ease, that's another technique that you can do. He calls this as a jerky technique. And of course, in those places where you do not have a femtosecond laser to dissect the channel, you can also do with manual channel preparation, as Jack Parker from US has been doing also. We get a lot of decreased in the coma post-CARES, and that's one reason why patients are extremely happy with their vision post-operatively. Of course, you also get a decrease in all the other parameters as well, as we showed in our pilot paper on CARES. We also used it for a number of cases of post-LASIK ectasia now, all of them giving great results with improvement in topography as well as visual acuity. We've also used it to replace the need for a DALC in many patients. You can delay it in 100% of the patients, and of course, you can also avoid it in a large majority of patients. In all my patients, I've had to do a DALC only in one patient post-CARES, and that was a patient who was lost to follow-up during COVID. You can also combine it with bioptics, with topograded PRK, and so on and so forth. And you can, in these advanced cases, avoid all these complications that can sometimes be associated with DALC. Then one of the advantages of CARES has got a very easy learning curve, and it's really a very easy procedure which can be adapted by refractive surgeons, cataract surgeons. It's not really a very cornea-intensive kind of procedure. And another big advantage that I feel is that it leaves the visual axis completely clear, unlike some of the other additional technologies. So there's no chance of an interface haze, no glare, no loss of contrast sensitivity, or anything like that. So to conclude, I'd like to say that, this is really, I feel, a great way to correct keratoconus and other ectasias. It's safe because, as I said, the visual axis is not touched. It's safer than plastic segments. It can replace DALC in many cases. And the beauty is you can also insert it in all kinds of keratoconic patients, right from very mild to very severe cases. So it kind of covers all the entire range of keratoconic patients and gives you great results. It's also reversible. It's adjustable. It's simple and safe. and it's got a very low level of rejection. So because of huge number of reasons, which I've illustrated here, but I won't go into right now because of lack of time. We've got now a great experience with CARES. We started this in 2015, and we've got now about 8 years of experience, and we've found a very low level of complications and great efficacy, and with a lot of patients actually referring other patients, and patients coming in just by word of mouth getting CARES done. So thank you so much for giving me this opportunity to share my experience, and I'll conclude my talk.
Thank you, Soosan. Thank you for this great invention. And I have a question, because I really think, allogenic material is more tissue friendly than PMMA. Can you, or do you also cross-link these allogenic rings, and can you perhaps freeze them to make them more firm and easier to insert?
Yeah, that's a great question, Pavel. And yes, I have tried doing that to kind of cross-link it and then put it in. But I really don't think it makes that much of difference, because make it easier, cross-linking is not going to give you that amount of stiffening as you saw with Sherry's technique of just dehydrating it. It just becomes so much easy. It's literally like
beautiful.
And plastic, and he calls it the jerky technique. So you can just push it in like that. So that's a great thing. And Jack Parker from US had also started dehydrating it, but not to the extent that Sherry does. And he was also dehydrating it just so that its volume decreases, and you can push it in, push more tissue in that way. So I don't know whether cross-linking the segment per se would give it any more advantages, but it anyway gets cross-linked, because most of my cases I combine with cross-linking. So along with that, the tissue also does get cross-linked.
Okay, but to understand you well, dehydration you think is the best tool to make it easier to insert these rings, correct?
Yeah, Pavel, actually, dehydration is a great technique, as you saw, but I don't think you really need to do it for every. It's not a must. It's really a simple procedure. CARES, you have the right instruments and you can do it. If you have a curved Y, then you can easily push it in and get it into position. But if you want it to become even more easier, you can do this. The thing about it is that because it's allogenic tissue, you need to maintain a dry surface if you're going to dehydrate and put it, because the minute it comes in contact with BSS, it just becomes soft very soon again. So if you're dehydrating it, you need to push it in fast, and then not wet the surface at all at that point of time.
Wonderful.
Yeah, Soosan, I've got to say thank you from my side too. Since I started doing CARES, I haven't used a synthetic implant. I think your natural progression out to customizing them makes so much sense. And I like the way how the tools you've designed, you can do it simply enough, without having a femto to actually cut it for you. Just tell me if I'm right or wrong on this. Is this procedure is working not in the same way that an Intac or a Ferrara ring would, by forcibly changing the corneal shape? It's really by adding volume, isn't it? By adding bulk.
Yeah, absolutely. So CARES, I feel CARES works in 3 ways. One is the majority of effect comes by adding volume. It adds volume and flattens the cornea that's central to it. So that's one great way. And it doesn't just flatten the cornea central to it, it also steepens the cornea on the other side a little bit, which kind of regularizes the entire topography. It makes the cornea much more regular, and that gives you much better vision and quality of vision as well. The second thing that it does is, I also think it does give you some amount of arc shortening effect, or a false limbus, because that's also something that it's doing. Even though it's not as stiff as an Intac, it still does do that just because of the volume that's added. And the third important way that it acts is because of epithelial remodeling. So the epithelial remodeling again acts with time, as the epithelium keeps growing into better shape, and you keep getting the slower effect after the immediate effect that you get. I think Sherry has again done great work on actually studying the epithelium epithelial changes post CARES, and he's actually going to be sending out that data soon for publication as well.
So Soosan, I have a question. First, it's wonderful. You're always coming with a very innovative approach for fixing a lot of complicated situation. And my question is, since you create a situation that we have so much freedom of customization now that we didn't have in the past. We have a few rings that we could pick with a few parameters that we could play with. Now, since we have almost like a full freedom of customization for the cares. Do you foresee, or probably you're already working on that, but an algorithm that can work with AI? You just have to show the topography, and then you just have the laser can do that. Here's the topography, so here is the how the cares should look like.
Yes, actually, that is something that we are working on now. And you're right, CARES gives you this freedom. And I think that is something that's very important. Synthetic segments, we know that, even though you do have progressive synthetic segments, or say progressive thickness synthetic segments, they're very standard because they start at one end, at one thickness, and then they go continuously across to the other end. And then you get them in only certain standard thicknesses. You get them either clockwise or counterclockwise, and then you have to have this entire inventory with you, for different patients. So it really frees you up from all that. Some patients you'll want, the length of the part segment that's uniform thickness and the length that's tapered in one side or both sides. You might just want to customize so much. You might want to have a longer segment, which is of uniform thickness, and the short taper, or in some other cases, you might want a long taper. So this customization really helps you to do all of that. I think femto will also play a major role in the future in being able to customize it further once the actual software gets into place. Maybe you'll be able to do a lot more with that as well. But currently, what we use, the instruments that we use, really help us to customize it to a very satisfactory level, actually. And we are getting great results with that. And yes, we are working on a nomogram, which hopefully, as you said, we'll put it in with AI, and you show it that, and then it does something.
So that would be fantastic. I look forward to that. And my other question is, do you think, I think Alio is doing something probably similar. I'm not sure, but he's doing some kind of tissue engineering to kind of fill this area of thin cornea. Now, since you put there more volume with the corneal tissue, is there any way you could see in the future to add, after cares, any topography guided laser ablation over this area to smoothen even more the shape of the cornea, since you have added some tissue there? So do you see an extra procedure like that might be helpful?
Yeah, I think that definitely is something that you can work on further. Some people are already doing this because there are a lot of surgeons who have been using topo-guided PRK for keratoconus for many years. The limitation they used to face was that the amount of tissue they could remove was limited, obviously, and it's still going to be limited even with CARES. But because of that, the effect they could get was minimal. Now, what you can do when you have CARES is that you put in CARES as the first step. So that gets rid of the bulk of the the steepening, and it just takes care of the bulk of the keratoconus management, and then you can do some fine tuning over that with topo-guided PRK, which will really maximize the effects that you can get overall. So topo-guided PRK is a great thing that you can combine with it. I'm a little bit hesitant on topo-guided PRK for removing subtraction, for doing subtractive procedures in keratoconus, but I know the great surgeons and people whom I respect so much who are doing this, and they're so happy with their results. And I think that definitely is one of the ways to go forward. You could combine it with phakic IOLs, you could combine it with topo-guided PRK, you could combine it with maybe a refractive lens exchange in some cases. So there's so many things that you can actually combine it with.
Yeah, so actually I agree with you, because I'm also not a huge fan of PRK topography guided on a keratoconus cornea, but I think you have in hand something that might overcome some of the fear of doing PRK on the topography guided PRK on the keratoconus cornea by having this additional tissue there. So I think that might be a great combination, to have some kind of touch up on the top of this additional volume there, and probably cross-linking after that.
Yeah, I completely agree.
I think, another point to go back to your epithelial talk, David, is I've done a number of cases like this where there's still a very small central irregularity. And then those procedures you do transepithelial topo-guided with no power. And it just takes away that irregularity centrally, and it makes a significant improvement in these particular cases. It makes a big difference. So I think topo-guided PRK versus transepithelial topo-guided PRK are two different matters. And when you're doing it transepithelially, the amount of tissue you remove is significantly less from the stroma.
I would love to ask you, Soosan, if I may, did you ever think of different sizes of the double blade trephine you're using for various types of keratoconus, or you're just using the ones and same size for all the cases you have in your practice?
Thanks for the question. We have currently 3 sizes of trephines. One is at 7.75, the inner diameter, the outer diameter is 8.75. One is at 6.5 and 8, and the third one is at 8 and 9.5. So the reason we have kept it as this is the 7.75 and 8.75 will give you around 0.5 millimeter of tissue thickness, which we can use for the milder keratoconuses. And also the 7.75 is the inner ring of tissue that's left is can also be used for a DALC or an OPK. That size is quite good, 7.75. Similarly, the 8 and the 9.5 that we have taken gives you thick tissue because it's more from the periphery, of the donor. So that gives you thick tissue. And also the 8, again, the ring is again a commonly used size for DALCs or penetrating keratoplasty. So again, the inner tissue can again be used for a different patient if the country's legislation allows. I know in Europe, many countries do not allow the same donor tissue to be used for 2 patients, but there are other countries where it is allowed. And if that is allowed, that's possibly a way that you could maximize use of the donor tissue. The 6.5 and the 8 is, I think, the commonest one that we use because it gives you great results and it kind of covers the majority of keratoconus patients. So currently there are 3 sizes, and also there's one more thing that you can do if you want to kind of, you think that you want to kind of change, increase or decrease your effect a little bit more. It's actually quite easy to just cut that ring into a linear segment, lay it out on the side, flatten it, and then just put a linear cut across the segment. In case you want it, a little more thicker, you can just do that. And there's another thing that I do, which I call as augmented cares, where when I want even more effect, let's say with a 6.58, I kind of don't keep it as a linear tissue spread out evenly, but I kind of bunch it up and push more volume of tissue into the same tunnel. And that gives you a greater flattening with the same amount of, with the same thickness of trephine that's being used.
Thank you. When you were talking about maximizing the usage of the tissue, so did you ever perform DMEG and then cut rings?
That's a good question because we do not perform DMEGs at our center. We perform only PDEX, pre-Descemet's endothelial keratoplasty, which also takes in the pre-Descemet's layer. We do not do DMEX or DZEX. They're completely out at our center. So therefore, the tissue that we get after doing a PDEC has air in it. It's got emphysema in it because that's how you create the PDEC bubble. So it's an emphysematous tissue, and that is not ideal for cutting for rings, just because it's soft and it's kind of spongy, and it would go inside you would cut a certain amount of tissue. You would cut with the trephine thinking you've got a certain amount of volume, but when all the air is absorbed once it's inside the patient's cornea, and it just dehydrates, and you would be left with a thin rim of tissue, not what you actually thought you got. So we wouldn't use that. But if you're doing DMEC, yes, you could, because in DMEC, the stroma is completely virgin and you could just go ahead and use that.
I had a similar question if you could use the periphery of the cornea after PKP. I think you can also cut that and then spread it, and that also save the tissue, correct?
Absolutely, you can do that. And that's exactly the reason why we also kept the trephines in those sizes. 7.75 is one that you can use with maybe a 7.5, host cut, and then you get the 7.75 donor cut, or you could use a 7.5 donor host cut, and then you could use the 8 one for the host. So that kind of, it's also done with that, keeping that also in mind.
Okay, very, very interesting. Any other question or comment?
No, just a really interesting day with a very good variety of lessons and innovations, and super day. Thank you very much to all the speakers, all the contributors.
That was a great session. Thank you. We would like to thank you together with Arthur for accepting our invitation and for contributing to AECOS webinar by such an interesting talk. Thank you. We really appreciate that. And I think we are going to invite you again.